Welcome to the Joint Legislative Oversight Committee on Health and Human Services. We are delighted that you've chosen to spend your morning with us. Now would be a good time to silence all of your electronic devices and have your seats. We'll start out with introducing our House Sergeant at Arms for today, Young Bay, Terry McGraw, and Jim Moran. Our Senate Sergeants at Arms are Francis Patterson and Billy Fritcher, and we're delighted that you ladies and gentlemen serve us in such a professional manner. The agenda for today has been approved by the chairs, and we will see, first of all, if there are any remarks from the co-chairs. Representative Lambeth.
Well, it's good to see Senator Heiss here. We know he's had some challenges in his family. We're glad to see you here.
And Senator Dobson. Senator Dobson says he's good. Remains to be seen. But we're glad to welcome everyone here today for this important committee meeting. The next item on the agenda is the comments from the Secretary. Secretary Cohen, you are welcome to this committee hearing, and we will be glad to entertain your remarks at this time.
Well, thank you so much, Chairman Pate, Chairman Dobson, Chairman Lambeth. Thanks for having our team here today. I think we have a lot of really good agenda items to talk through. One update since our last meeting, we spent a fair amount of time talking last time about the Children's Health Insurance Program. Wanted to remind folks that Congress has not yet reauthorized that program. The House has passed a version. The Senate has not yet. We continue to be able to provide insurance coverage to children uninterrupted, but we are obviously watching very closely for congressional action in the December timeframe, though they have a lot on their plate in the next month. So we would be back to you in the January timeframe if there was no congressional action with how we would need to step through that in terms of enrollment freezes and things like that. I hope we don't get there and action happens quickly in D.C., but just a follow-up there. Second, we're going to spend a fair amount of our time this morning talking about the opioid crisis. Dr. Susan Consagra, who leads that work for us, will step through it. I think that has been a place where there's been tremendous not just bipartisan, but multi-stakeholder effort in this work. So I just want what you will hear about today, while presented from our department, is really the result of work from really across the state and work here at the General Assembly, and want to make sure we continue that great momentum forward. What you will hear about from us is the link between treatment and prevention and the crisis. So you'll hear a fair amount about that. And so I wanted to just mention right at the start, we are right now in the 45 days of open enrollment on the individual market, where healthcare.gov is open, where folks can go who don't get their insurance through work, can go and shop for insurance for their family. We know that 90% of North Carolinians can go to healthcare.gov and find a plan for their family for $75 or less, 90%, so that's pretty good. So we're encouraging folks, again, to go there and make sure that they know that the open enrollment period is shorter this year, and obviously there's been a lot of talk about it and maybe some confusion, so we just wanted to make sure to take the opportunity here to remind you all, and I'd love to make sure that you all are helping us communicate about this 45-day period that ends on December 15th, where folks, again, can go and shop for insurance. And we think, again, 90% of North Carolinian families can get a plan for $75 a month or less. So that's great. And then the one other thing that you asked me to give a highlight on before I turn it over to the rest of our team was an update on where we are with our preventing and detecting fraud, waste, and abuse. So let me walk through that very quickly. So essentially, good Good news. Okay, there we go. So just to remind folks what the goal here, again, this was to use our technology solutions to identify scenarios where there could be fraud, waste, or abuse. So we've spent the last number of months working with our contractor to scope out exactly which areas we wanted to focus on. There are some related to the providers of care and some related to those who are recipients of care. So now we have scoped out all of those issues. We have, on the provider side, we're looking at providers with bankruptcies or providers with expired licenses, sex offenders, or who are deceased. And then on the recipient side, same in terms of incarcerated, deceased, or living outside of North Carolina. So in terms of status, like I said, we've scoped out now all of this work on the provider side. We are implementing this month the provider side of that. So that is already ongoing and should be, by the end of November, have our first run of the information to compare providers against those particular scenarios. On the recipient side, that is where we have spent a fair amount of time making sure we were getting the data right and the scenarios right, but we now are at that point. It is fully funded, and our contractor, CSRA, is developing that for us. We believe that in order to do it right, that the first time we'll be able to run it is April of next year. So, but we're on track to complete all of that work. So with that, I'll turn it back to you, Chairman Pate, and happy to answer questions or move into the agenda.
So did I understand you to say that you feel like the department will be ready along with the vendors by April of 2018 to really take a swipe into this?
So for the first three scenarios there, we'll be able to do it this month. Those first three scenarios there, the latter three scenarios is an April timeframe. So the ones related to providers we'll be able to do right now, and the ones that are recipient focused will be April.
Any committee members have questions of the Secretary on this subject? Senator Krawiec.
Thank you, Mr. Chairman. Madam Secretary, thank you for the information. I was under the understanding that the program was supposed to be running by the end of November for all of those recipients and providers. Am I mistaken on that, or are we just behind schedule?
So we are running fast to do the things that the General Assembly wanted us to do, which is why we were able to get the provider piece up and running in November. It took us a bit longer to scope out and understand the exact parameters that we needed on the provider side, again, to make sure we had the right data sources, that we were doing this in the right way. It took some time for us to work with our vendor on that, but now we've scoped it, we've funded it, we're building it, and so we think we'll have it up and running by April.
Follow up, Mr. Chairman.
Yes, go ahead.
This is a little different question, but I know that a couple of years ago we passed the legislation where there were some eligibility requirements for work on receiving the benefits. Do we know how often we are checking that eligibility requirements? Are we doing that on a regular basis, or do you know where we stand on that?
So I don't know that, but I'm happy to take that back, and we can come back to you with that answer.
Thank you very much.
No problem.
Further questions from members of the committee? Senator Heiss.
Thank you, Mr. Chairman. Two quick areas I just wanted to follow up on. For the NC Tracks enhancement, how broad of a scope are you looking at when we're talking about providers as well as recipients? Is this all federal benefits? Is this limited to Medicaid benefits, or are we doing that tracking of where they're spending the benefits as well for out-of-state residents? I'm just trying to get a sense of what necessarily is the scope.
I might turn it over to Dave, but I think it's just Medicaid. And I think that was the scope of what we were charged for. It was Medicaid benefits, but I'm looking over, yeah.
Follow-up.
Yes.
And I think we might see the sense of what's next. This will come again. But along this, I know that the expectation is that beginning with investigating providers this month and with individuals coming in April, that there will at least be a large initial caseload going through of individuals we identified. And for your program integrity and potentially investigative units, how is your staffing holding up there, and what do you foresee as kind of forecast for additional needs or different needs next year?
Senator Heiss, Dave Richard with Medicaid, and I appreciate the question. You would be shocked if we said to you that we didn't think we would ever need more staff to do this work. What I would tell you, though, is that we need to do the evaluation of that, and we've been working through it. I think last year we had asked for a few extra positions in program integrity, and really that's what we're trying to do. But I'd also add is that what we want to come to you with is what is our staffing pattern needed for this, but also as we're transitioning into managed care, to make sure that what we're asking for is not something that this year we need this, but next year we need something else. So we're talking about a broader, long-range picture. So that's what you can expect to see from us.
Further questions? Representative Murphy, Dr. Murphy.
Thank you, Mr. Chairman. I just had a question. What is your expectation? Going out before looking for fraud and abuse, what is your expectation of how much will be found?
It's a great question. Looking at other states, actually, we think that the expectation will be on the lower side, but I think that's why we're doing the exercise here, and I think by the end of November we'll at least have a first tranche on the provider side, and then April on the beneficiary side. But looking at other states that have done similar work, it's actually not. I don't think that we're going to see a huge number here, but we'll see.
Further questions from committee members? Senator Behringer.
Thank you, Mr. Chair. My question is, first of all, yes, thank you for your presentation, and this is obviously a big project and a heavy lift. Is this in any way going to slow down the process for the Child Protective Services and other NC tracks support that we're looking for as we move forward with the DSS and DHHS changes?
Well, thank you for that question. Thank you for the question, and I want to make sure you know that, no, we feel like we are adequately resourced to handle all of the work, and I think also sequenced differently, so that I think this will be up and running and working and through our Medicaid work, and that a different team of folks will handle the work on the DSS side and the changes that needed there. But it's a lot of work going on across the department, a lot of balls in the air, and we're appreciative of the support that is needed for us to make sure that we can execute on all that work.
Further questions from committee members? And the chair has a couple of questions on the current identified scenarios addressed on your slide. I believe I heard you say that the top three items there, the providers, would be more easily detected than the last four. Was that your comment?
That's correct.
So the state doesn't have any way of quickly determining who's deceased in our state, or we don't know who's incarcerated, or we don't know who gets their checks mailed outside of North Carolina to them?
Well, I'll take the deceased one. I think this is a topic that this committee has probably heard about before, is that our death registry is not an electronic source of data at this point, so it is not as easy as you would want it to be to bounce our data off of a death registry. It is done. But I think what this is doing is speeding that up and allowing us to do it on a more frequent basis. But I'll let Dave, who knows more of the details.
Senator Dave Richard, I think it's a great question. With the advantage of what we're trying to implement now with CSRA is that we'll use more data sites to be able to determine these things. So, for instance, the deceased provider or recipient, obviously the Secretary said we're waiting for our death records. Well, there might be some indicators elsewhere that you might find out on the web, other I'm not a technology guy, but I'll use it that way, through technology sources. Incarcerated recipients, the same thing. If somebody might wind up in a jail in a county that they're not from, we may be able to find that out through other sources. And then the living outside of North Carolina, the piece that I think is where a lot of folks have heard this is that, if you're someone who is in North Carolina and you move to another state, say move to South Carolina, well, you may not tell the DSS office that you've moved, maybe because you just forget to do that. Well, other ways to detect that through other social media sites and other ways to do that. So that's the kind of functionality that we'll have with the system, is that we'll actually have more sources to look at. And then one of the things that when Senator Heiss asked the question about staff to review this, is we want to make sure, because you might find something from social media where somebody looks like they live in another state, but actually they're not. So we need to be able to track down that information. What this will allow us to do is see things that we've never seen before and then make decisions on how to review it.
Further questions from committee members? Hearing none, thank you very much, Madam Secretary, and also Mr. Richard for your comments. Next, we'll move into item 3, telemedicine study and recommendation. Ms. Maggie Sauer, Director of the Office of Rural Health from the department, will address us now. Ms. Sauer.
Good morning, everyone. It's a pleasure to be here, and a pleasure to serve as your Director of the Office of Rural Health. We have been, we believe this study is particularly timely with so many of the activities regarding access to care for our citizens and folks who have special needs in the state. So we're grateful for the opportunity to present this information to you, and grateful for the work that you've done so far in providing some opportunities for payment around some of the telemedicine procedures, as well as working with telepsychiatry and the work that's happening with ECU. To get straight to your report, you'll know that the report is a 35-page document. I know that everybody's ready to use that and go to sleep with that at night, but I would urge you to read, to more acutely address your questions that you had for the report on pages 6 through 9. So if you had to look at the report, that would be the largest body of information for you. We do believe also that this provides us with a unique opportunity and time. Your question, particularly with regard to the 1115 Medicaid waiver, and the work that all of you have done around looking at broadband infrastructure. Those are two really major points that will serve us well in the future as we move through this together. Critical to that, I think it's important to begin to think about telemedicine not as a separate service necessarily, but it's a mode of delivering care. And I think that's one of the most major points that people need to wrap their head around, which is that we're really talking about providing quality access to care for folks who normally may not be able to access that care in any other way. And it's really talking about trying to create standards, trying to create strategies, trying to create policies that will allow us to ensure that access, that high-quality access to care. So very quickly, if you'll permit me, I just wanted to read what the current definition of telemedicine is, and something that DHHS is recommending that we adopt. It has been proposed by the Health Resources and Services Administration as the use of electronic information and telecommunication technologies to support and promote long-distance clinical health care, patient and professional health-related education, public health, and health administration. The technologies include video teleconferencing, the internet, store and forward imaging, streaming media, and terrestrial and wireless communications. And in fact, CMS has adopted that definition as well, and the DHHS would recommend to all of you to also adopt the American Telemedicine Association definition for your consideration. And as we move forward to recommendation 2, it is important, I think, to think that there are other organizations. All of you have been forward-thinking in how you want to manage and organize telemedicine services for our citizens in North Carolina. The recommendation, just basically to increase access to care, just as if you were sitting in your doctor's office, we want to make sure that the standard of care that someone would receive through telemedicine is the same regardless of where someone experiences care. Improves patient satisfaction. And of course, I think something that all of you have been dealing with in terms of not only access, but can we do this in a way that provides us with reduced costs but improved patient satisfaction? And so I think, again, you'll notice a lot of these questions or a lot of these concerns really do follow what we're talking about with regard to access to good primary care. So, engaging practitioners to practice at the top of their licenses. And those conversations are not different than what we've been discussing in terms of having face-to-face encounters with this. The North Carolina Office of Broadband Infrastructure 2017 Broadband Report recommendations with regard to looking at data transfer speeds. I know that all of you look at these activities and this information not only from a healthcare perspective, but also the economic development of our communities. And when we're looking at the transfer speeds, particularly for telehealth services, we want to make sure that it's, again, you're not looking at someone and trying to provide care if you can't clearly see them, and they can't clearly see you. They can't be heard in the way that they need to be heard, et cetera. So that report is critical to helping us make sure that not only our communities have the support for education and commerce, but also increased access to care for some of our most rural communities. So we would recommend, certainly that those recommendations are followed, and certainly that in that activity, just as you want to be able to make sure that your records follow you from one practitioner to the next, that participating in the North Carolina Health Connects is a way of helping to ensure that actually can happen. You can imagine how fragmented and so on records can be, but if we're introducing a new strategy to provide care, North Carolina Health Connects is going to be a really important piece in doing that. Informed consent standards. So part of what we make sure of as we provide service to our to patients and to folks who need care is following HIPAA, is making sure that in fact people understand what the service is that they're receiving, how they're going to receive it, and what their opportunities are to be concerned if the service is not provided to them in a way that they feel is important. So the American Telemedicine Association standards for informed consent include informing patients of their rights when they're receiving telemedicine, including the right to stop or refuse treatment if they decide that that's what they need to do, discuss the patient's responsibilities when receiving telemedicine treatment, providing a formal complaint or grievance process, just as we would if someone was experiencing face-to-face. Describe the potential benefits, constraints, and risks of telemedicine, like privacy and security. Informing patients of what will happen in the case that technology breaks down or there's a failure during the telemedicine session. So there is, I think, a bit more understanding and information and opportunity to teach what the differences are and provide the support so that so that folks feel fully engaged and fully informed of what it means to participate in this. Something that I think all of you will be critically concerned about is certainly online prescribing standards. As we're looking at the opioid issues that we have within the state, we have heard a lot around what happens with prescribing some of those substances and so on, and I would imagine one of your questions would be, what happens in an online kind of prescribing situation? And again, we would be recommending following or abiding by all the federal regulations for e-prescribing. So there are those acts, there are some federal legislation that's in place, which includes the Ryan Haidt Pharmacy Consumer Protection Act and the Controlled Substances Act. So there is some of that we can fall back on, and certainly would require folks to follow in terms of any online prescribing practices. With regard to provider licensing standards, we want to make sure that certainly people are following the licensure standards and so on that have been adopted in North Carolina. We do have some additional opportunities, however, with the Interstate Medical Licensure Compact, which allows people to begin to practice across state lines. North Carolina is a part of the Federation of State Medical Boards that is working on this issue, actually. We have not adopted the Interstate Medical Licensure Compact. There are 22 other states that have done so. And if we're talking about access to care, that may be something that we would want to consider moving forward on in order to provide additional access to care. With regard to private payer telemedicine reimbursement standards, it's been interesting. We do have standards from CMS that allow us to talk about what Medicare pays for. We do have Medicaid payment, obviously, for telemedicine services within the state. But I do think if you talk to many of the payers within the state, Blue Cross Blue Shield, United, many of these folks, there's not a standardized payment policy that has been enacted across. And I think people are really trying to look at what is the opportunity, what's the science, what is the state going to do? So I think there's an opportunity for DHHS, for all of you to decide what that standard could look like. Finally, the Psychological Interjurisdictional Compact, SIPAC, is something that we've spent a lot of time talking to folks about with regard to psychological services and what that might bring to North Carolina. The North Carolina Psychological Association has reached out to us and told us that they are in support of the opportunity to create opportunities for behavioral health providers across state lines to provide access to behavioral health care in North Carolina. We do believe that in the last two recommendations here, 7 and 8, that in particular we believe we would think that the SIPAC is something that would benefit North Carolina. But in these two recommendations, we also believe that there's an opportunity for additional discussion with a number of stakeholders that have an interest in this. And the final recommendation to all of you, I think, is just to ask for additional opportunity to study some of these opportunities, to talk about what some of this might mean, particularly with regard to the Medicaid waiver, when we know and we would like to require some form of telemedicine payment policy within the waiver that would allow access for folks to receive the care that they need and make sure that our rural citizens, our folks with disability, and so many people who are, in fact, restricted possibly by transportation, their responsibilities at work or caring for a loved one, I think this will open up a tremendous opportunity for us to really reach out and provide the access to care that we're all hoping for. Thank you.
Thank you, Ms. Sauer. At this time, we'll open the floor for questions from members of the committee for you or for any of your experts. Ms. Adcock.
Thank you, Mr. Chairman. Since you're talking about interstate compacts near the end, I'll give a comment. Nursing actually has an interstate compact, and we passed one for PT, if I'm not mistaken, this session. And I was just looking at the SIPACT website. There are 6 or so states that have done that. We're not one of them. So the good news is we already have many of these things in place, which leads me to my next comment, which I think is really foundational to this report. And that is we keep using interchangeably the words telemedicine and telehealth. I think we should pick one and stick to it, and I think it should be telehealth, because medicine's a part of that, certainly, but so is nutrition, so is nursing, so is physical therapy. I mean, I think right out of the gate, as we're building this, we need to build it broadly, and we need to help all of our citizens in all the services that they need, and in this mode of delivery of services, as you so clearly point out at the beginning of your remarks. And so I commend you on these recommendations. I think they're both specific and broad, but would make those recommendations to us moving forward, Mr. Chairman. Thank you.
Did you have any remarks to make after that statement?
Representative Adcock, I totally applaud you for that recommendation and the recognition. I think we have been focused a lot on whole person care, and we know that there are a lot of folks who provide care. Physicians are one form of care, but as you so astutely point out, it really is about a team of people who bring that care to the patient and in their home. So thank you for those remarks.
I might interject for members of the committee who were not able to take advantage of the opportunity that we had last week to visit the Caldwell County Medical Center and to see the wonderful job that they're doing up there. Truly, that is rural health at its finest. And I hope that all of you have a chance to see what's going on up there, and we can know that those patients are in good hands up there. Representative Dobson.
Thank you, Mr. Chairman. Director Sauer, thank you for your presentation and for being here. On the private payer reimbursement standards, that seems to be one of the more challenging obstacles we're going to have to work through to make this successful in North Carolina. Can you elaborate a little further? Is the department have proposals in place or recommendations to the General Assembly, or can you talk just a little bit more about how you all see the state going forward with regard to reimbursement standards concerning telemedicine?
Thank you, Representative Dobson. I think, as I said earlier, we do have some reimbursement policies around telemedicine that exist presently through our Medicaid, and CMS actually also has some of those standards in place. My feeling is that we really are trying to look at additional opportunities to measure the science around telemedicine also. I think that's where a lot of people are hedging a bit. We don't have a lot of information right now about the efficacy of some of this. We know that there are opportunities where this can happen when you are certainly providing consultation and so on from a provider to a provider. We want to better understand how that looks in terms of being better or the same. So I think there's additional opportunity for us to define what that looks like, and I believe that some of the private payers will follow that also. The Secretary may have additional comment on that.
Hi, it's Mandy Cohen. Just to add on to that, I think Meg is exactly right that Medicare and Medicaid have some models for us to look at, but I would encourage folks not to think about paying for piece by piece by piece in the same way we do with other medicine. But as we're thinking about alternative payment models more broadly in the healthcare space, I think this is where telemedicine can fit in nicely as part of overall care for someone. So again, as we move to places where there's capitated payments or even shared savings model, it becomes integrated in different ways. So you don't have to say, okay, I'm going to pay this person this much for 5 minutes of this for this level of, right? That gets very complicated really quickly. Rather, thinking about how do we think about creating an infrastructure for that and then utilizing it as a tool as part of these larger payment models. So then we're in a capitated environment, and then it just becomes one tool to deliver the right care to the right person in the right setting. And folks will look for the right place to deliver that care. But I also just want to reiterate what Maggie mentioned, is that as we move forward with this, I think we have to move down two tracks. One is on the infrastructure and the regulatory side, but the other is also on the evidence generation side, and that is where we're looking to work with our academic partners to make sure that we are building a robust evidence basis for this work. I believe that this is where we want to be going in order to make sure we're maintaining access to healthcare services in our rural areas in particular. But we need a lot more study about how different permutations of this can work. And so we're looking to make sure we're traveling down both those paths.
Thank you, Madam Secretary. Chairman Lambeth for a question.
Thank you, Mr. Chairman. I commend you on the thoroughness of the study, and I do think that the study actually highlights the need that we actually did the study, because it raises several issues. My specific question was, do you have an inventory of actually what is happening now in North Carolina across the state in telehealth arena, so that we actually know who's using it and how it's being used?
I think we have some of that. This is Mandy Cohen. I think we have some of that. We've done a fair amount of surveying, probably not comprehensive. What we have been doing is surveying the evidence base to help us guide our policy making in this space, and that's where we've found that there are certain gaps in the evidence. We certainly know that, and Maggie's team funds a number of infrastructure projects related to telepsychiatry in particular, but I wonder if we could work with some of our partners in the associations to provide more information to the committee on that, and with probably our Blue Cross Blue Shield partners as well.
Representative Murphy.
Thank you, Mr. Chairman. I want to personally congratulate you guys on the depth and breadth of the study. This is obviously a big need in our state. I would caution just some of the nuances of this. There's nothing that supplements a physical examination of a patient and presence, and there are indeed limitations to this. However, that said, there are hands down points of contact and points of care that can and easily can be handled via some type of electronic device. I'll echo Representative Dobson's problem. I think the difficulty is going to be our private payers. We have different populations that would benefit from this. We have the folks who are essentially homebound. We have people who are caring for other individuals. I think our most challenging population, and this is the burden that's going to come on us, is going to be our Medicaid population, because these are individuals who disproportionately use our emergency departments for primary care, also the uninsured who use our emergency departments and clog our EDs at nighttime for primary care. That said, those are the populations oftentimes that don't have the access to the type of electronic devices that provide telemedicine. I would urge that you guys or us as a whole come up with some type of, it's going to have to be a requirement for some individuals on Medicaid to use this rather than just going to the ED, if we're going to actually affect the change that we want to affect in that population. Just offering it, in my opinion, knowing this population, knowing the people that I take care of and the people who I see in the emergency department, I'm sorry, they're just not going to do it. And while I think this is a very noteworthy goal, we have to be very pragmatic on its inception and how we roll it out forward. So I think to put teeth in this moving forward in the future In that particular population, there's going to have to be some requirements put forth by us to provide that service that you must do this. So I would just ask that that be under consideration in the future.
Comments, Ms. Sauer?
I think you're exactly right. I do want to emphasize the fact, however, that we are not saying that someone should use this in place of necessarily a face-to-face encounter. You know, so I know when we've had many discussions with our stakeholders during the time where we're sort of creating the information for the study, that was a concern that we heard frequently from providers was, are we talking about replacing someone? And that's really not what we're hoping for. It's really trying to provide access to folks who can't. But to your point, you know, there are other states, one in particular that we talked to, which I was really surprised by in Tennessee, a group that was with the community health center. It's basically care that's provided to their community, a rural community, through a community health center, and they have a telemedicine component to it. And unbeknownst to them, there were many of the folks who were choosing to use the telemedicine opportunity instead of going to see them directly. And most pronounced in that example was young people who were about 21, 18 to about 30, who were interested in engaging in behavioral health services, and they couldn't get them to engage in any other way except through their phone or an iPad, something like that. So I think, to your point and to the Secretary's point, you know, there's going to be some age differences perhaps. I understand that. I'm not sure that's how I want to do mine, but I think to that point, you know, to truly address what people need at the time that they need it, this provides us another opportunity to address people's needs and get them the care that they need.
Thank you. Senator Heiss.
Thank you, Mr. Chairman, and these may predominantly be technical things I was wanting to get out of the way, but I'd like to ask first that the committee direct staff to draft legislation based on the recommendations for consideration for the short session. We'll have an opportunity to review it, but I'd also like to ask that we submit it to the IT oversight for the broadband infrastructure issues. That was the first one. And second one, I'd like to ask the department, I know that we're doing a lot with this waiver right now and the 1115 waiver, if they could submit us language specifically for incorporating telemedicine into the waiver to the committee. My guess is that might not be a vehicle that we want to wait till short session for. So if we could get language on that, and then if we as a committee could draft that for our considerations.
No objection from the committee chairs. I assume that would be fine. Secretary, you have any comments?
Just very quickly, Senator Heiss, just to let you know that we are thinking about how we can use our waiver to support telemedicine initiatives, so you'll see some of the details there. Essentially, we ask CMS for expenditure authority to allow us, if we want to do that. So we ask the question, can we use it for these kinds of work? So you will see that in our waiver work. But then we'll need to work with you on the exact authority and how we work through those details.
Staff understand the charge. Thank you, Senator Heiss. You have further questions? Senator Krawiec.
Thank you, Mr. Chairman. Actually, Representative Lambeth asked my question, but I do have a follow-up. Thank you, Ms. Sauer, for the presentation. This great information, and I agree with you. Telemedicine is a great opportunity for us in North Carolina to expand our health care to our rural areas. I wanted to ask you, are you aware of grant programs, funding programs for these rural areas through the USDA Community Grant Program for communities up to 20,000 population? Do you think that's something that we would be able to take advantage of here in North Carolina for those rural communities?
Thank you for the question, and absolutely. I think we have I think we have a tremendous opportunity here because USDA, Commerce, many departments are looking at this, and in fact, as you know, the Duke Endowment within our own state has put money towards this. So I think it's our job to think collectively about ways that this can impact our communities. USDA is one of them, along with other agencies that actually provide this. There's a number of grant programs from the Federal Office of Rural Health Policy and HRSA that are looking at trying to sponsor this and create pilots so that we do have the data that we can look at and make good decisions from. So thank you for the question.
Thank you. Thank you, Mr. Chairman.
Representative White.
Thank you, Mr. Chair. Ms. Syer, thank you so much for your report this morning. It's been very informative. In your review of other state programs, has there been a collaboration with home health, home care, public health? Because as Dr. Murphy said, sometimes there just needs to be that hands-on assessment. And has there been a collaboration with those other entities that could provide in the home that hands-on assessment that could then be translated through the telemedicine telehealth program to the attending physician?
I'm happy to report yes.
Great.
And I'm further happy to report that it's happening in North Carolina. Roanoke Chowan Community Health Center and Ahoskie has a telemonitoring program that's been very successful. In terms of monitoring those patients that have chronic disease, heart disease, stroke, and all of those things, whereby they actually do monitor those patients at home. So there are things like a blood pressure cuff. There's a scale. There's, some of those things that just allow you to check in on patients on a regular basis. So the answer to your question is yes. The difficulty, though, is that's not necessarily paid for. So what we really hope can happen is that we're not just, we can provide service and payment for those telemonitoring services because they do lead, I think, to overall improvement in people's care. People don't have to come to the doctor as often. And to your point, they're not visiting our emergency departments.
Follow up. The program that Senator Pate referenced in Granville County they don't have the telemedicine component yet, but all of the other comprehensive clinic services that are now being extended through EMS and through to the homes of the clients is a great example of what you just described as the need. So that is a great program there. So thank you so much.
Further questions from members of the committee? Representative Cunningham.
Thank you. I want to follow up on Representative White on the monitoring services, but I'm going to put it in a scenario. So if you have a person at home that has congestive heart failure and they have to be weighed every few days and they gain 5 to 10 pounds within a day, then we know they're going into congestive heart failure. So that service is not covered if they're monitored at home at the current time. Thank you. That is a huge concern that's not covered because we know eventually they're going to end up at the hospital and they're going to be in total congestive heart failure probably by the time they get there. So that should be on a preventative side that we could see if that could get covered. Thank you.
Anyone from the department care to comment on that? I would suggest we would be looking into that. Representative Cunningham, thank you very much for bringing that to our attention. Further questions? Senator Davis.
Thank you, Mr. Chairman, and appreciate the presentation, and kudos to you and your team for working on this. Coming from a predominantly rural area, I particularly am grateful for this new technology that will allow health care to be available for more people. Coming from, and this may be addressed in other presentations having to do with controlled substance reporting system and opioid, the crisis. Are there unique challenges with telemedicine that will prohibit us from knowing who's prescribing what to whom? Because I got from your presentation that telemedicine can go across state lines, and so I wonder about state law. One of our goals is to drive people to use the controlled substance reporting system so we know who's getting what from whom. Could you describe the unique challenges that you may be faced in telemedicine in that goal?
So I'm looking at my team members here also. I think I'll hand this to Secretary Cohen.
Sure. What I would say as we step through this, and Charles is going to talk about it in a bit, related to the reporting system, is making sure that we have access to data across state lines, so that is something that you will see coming online very soon here for North Carolina. And as we would think about implementing telemedicine, I think you heard the standard we'd like to adopt is an e-prescribing standard, as well as making sure that the data is tracking, and either whether it's using the HIE or other source of data sharing. But we definitely want to maintain an understanding of who's prescribing what to whom. I think that integrity needs to stay intact as we, even if we're having a modality that is remote. So I think those are the things that are incorporated in some of these recommendations.
Further questions from committee members? Seeing none, thank you very much for a very good presentation, and we have a lot of things to learn, and hopefully this will be in our ballpark. Thank you. Next on the agenda is the Department of Health and Human Services strategic plan to address the North Carolina opioid crisis. Certainly something that has received a lot of attention and will continue to receive a lot of attention. We'll start off with Secretary Cohen.
Thank you, Chairman Pate, and thank you to the committee for allowing us this opportunity to update you on this really important topic. As you know, I've been focused on three things since I've joined the team here in North Carolina. Number one has been the opioid crisis. Second is on Medicaid transformation, we'll spend most of the afternoon on. And third is on early childhood health and education, which we spent most of our last oversight session talking about. So thank you for spending the time on this. I'm pleased to introduce you to Dr. Susan Consagra, who we're very lucky to have to lead the opioid effort out of the department. She is the section chief for chronic disease and injury in the Department of Public Health. She's a physician. We trained together at Massachusetts General Hospital, so I can speak to her clinical skills as well. But then she was also Deputy Commissioner of Health in New York City and did a ton of work in New York City, so has run big things. So we're very lucky as a native North Carolinian for her to have come home here and to run this work. And she's done a terrific job, and really it was her leadership that drove us to be able to release the action plan for the state that we did back in June. And what we're going to give you is an update both on the data of where we just are with the epidemic, but really wanted to give you an update on where we are with implementing that action plan, because the action plan is just words. What we need to do is make sure that we are getting on the ground and getting work done, and that's what Dr. Consagra is thinking about every day.
Thank you so much, Secretary Cohen, for that introduction.
Dr. Consagra, let me introduce you more formally to the members. I believe this is the first time you've been here.
That's right.
I miserably failed the test on how to pronounce your last name, but Representative Secretary Cohen has got me straightened out on that.
Yes.
But the floor is yours. Thank you very much, and welcome back to North Carolina.
Thank you, and thank you so much, Chairman Pate, Chairman Dobson, Chairman Lambeth, and the members of this committee for allowing me to speak on this critical issue. I know you hear about it every day from the constituents and see the impact in your communities, and we do as well in speaking with our many stakeholders. So I'm excited to give an update on this work. I want to spend a few minutes on the data and giving you an overview of where we are now, and then really speak about the initiatives that are underway, not only at the department, but really across the state in thinking about how we combat this epidemic. So first, to start off with a few data points, 3 people on average are dying each day from opioid overdose in North Carolina. And I'm sad to report that, unfortunately, I'm going to very soon have to change the slide to 4 people a day because, as we know, overdose deaths are increasing and have been over the last several years. If we look across our state and at the counties in North Carolina, we see that the death rate is correlated with where we have had historically higher rates of outpatient prescribing of opioids. So you'll see the dots represent outpatient prescriptions dispensed per 100 people, and the shading in green represents, the darker green represents where we have more overdose deaths, and you can see that there is a correlation between both of those things. And while initially opioid prescribing was a part of the way doctors were trained, those drugs were heavily marketed, oftentimes it was the first line that was being used. Now we know much more. We're seeing the impact of this every day, and a lot of our efforts are on, that I'll be describing later on, thinking about how we train providers. For every one of those deaths that we have in North Carolina, we have about 3 hospitalizations, about 4 emergency department visits, and many more people reporting misuse of prescription pain relievers across our state. So we know that when we talk about overdose deaths, it's really just the tip of the iceberg that we're seeing. This graph really hits home what's happened in our state over the last 15 or so years. If you look back in 1999, we had about 100 overdose deaths in North Carolina, and now in 2016 we had about 1,300. The other thing I'll point out in this is you'll see the blue and the green shading. The area in blue represents those overdose deaths that involve illicit drugs as well, things like heroin and synthetic narcotics. We know that as these other illicit drugs become more available in our communities, they're cheap, they're easily accessible. People are starting to shift to these more harmful drugs as well. If we look at the ED visits in our state, you'll see that over the last 8 years, we've had between 2,000 to now 4,000 emergency department visits. 2017, we haven't completed out the year yet, but you'll see we're already at 4,200, so we're set to exceed our previous rate. We also receive data points on those visits to the emergency department, and one of the data points that we get is the insurance status of those that are presenting to our ED for overdose, and you'll see that about 14% have private insurance, 27% have Medicaid or Medicare, about 50% are uninsured or self-pay, and that really hits home. Access to insurance like Medicaid is really critical in providing long-term recovery and support for those people that are coming in and out of our EDs. One of the things that we hear from providers is oftentimes the emergency department is where people are presenting, and sometimes repeatedly presenting, but certainly with something like substance use, which is a chronic condition, we need access to long-term treatment and recovery. So now I want to spend a few minutes talking about our response and coordination around this epidemic. And this represents work across many stakeholders in our state. This really tests your knowledge of logos for organizations. It's just a snapshot, but many different groups across our state are working on this issue. And they have come together through the Opioid and Prescription Drug Abuse Advisory Committee, and this was a committee that was established back in 2015 by session law. It has grown to over 150, and actually by last count over 200 members, organizations across our state that work together in different committees. So for example, we have a Prevention Public Awareness Committee, Intervention and Treatment, Professional Training and Coordination, our Data and Research, as well as our Community and Law Enforcement Committees, all participating in this advisory committee. One of the other initiatives that this advisory committee had started was creating a strategic plan, and we, this past year, as the Secretary mentioned, worked with the stakeholders to put together an action plan, really outlining the key initiatives that these stakeholders felt were most important in moving the opioid epidemic forward in our state. And I'm going to go through those action strategies and some of those action items. So broadly, those strategies were reducing the oversupply of prescription opioids. As you saw on that initial slide, really this is how the epidemic started. Second, reducing the diversion of those prescription drugs and also the flow of illicit drugs into our communities. Increasing community awareness and youth prevention as well. Making sure that those that are suffering from addiction and particularly having overdose have naloxone available to them and linking those survivors to care. Expanding access to our treatment and recovery systems of care. And then lastly, measuring our impact and revising our strategies based on the results. And for each of these strategies, folks weighed in on the key action items for each of these pieces. So I'm going to go through a few of those, starting with the first. One of the initiatives that we are undertaking right now is in collaboration with the North Carolina Hospital Association and hospital systems across North Carolina. They have come together to form a group called the Coalition for Model Opioid Practices and has about 70 to 80 members across our state participating in the various health systems. And this coalition committee is coming up with a set of interventions for our hospitals to build on already a lot of the work that is being undertaken. So, for example, thinking about what is a model discharge plan for those that are leaving emergency departments? What additional guidelines can we put in place for providers that are prescribing? Are there additional guidelines we could be prescribing surgeons to better fine-tune how we prescribe after procedures? So those are examples of the types of things that this multi-stakeholder group is thinking about, particularly as it relates to providers and health systems. Second, and thanks to the leadership of members of the legislature, thank you to you all. STOP Act will go a long way in promoting appropriate and judicious prescribing of opioids, particularly for acute pain. The requirements will go into effect for prescribing in January, which requires providers to prescribe 5 days or less for acute pain or 7 days or less of opioids for post-surgical pain. And so we think this will go a long way in decreasing the amount of unused opioids circulating in our communities, and therefore also preventing further, youth experimentation and other downstream impacts of this. One of the other initiatives that we are undertaking and have heard from our providers and health systems is convening together the payers across our state, the health insurers, as they set such a large role, an important role in thinking about how we can promote judicious prescribing of opioids, also promoting safer and more comprehensive alternatives to pain management, improving access to naloxone, and really engaging and empowering the members in their plans to engage in the management of their health. So we are looking forward to convening payers. We are participating in this as a large payer, Medicaid obviously, but looking forward to convening the other payers across our state to think about this, and our first meeting is in December. Particularly as it relates to Medicaid, some of the pharmacy benefit changes that were recently made by the team there in August implemented prior approval for opioid doses which exceed 120 milligram morphine equivalents per day, and also greater than a 14-day supply of any opioid. And so this was, again, with the hopes of promoting more judicious prescribing of opioids and really aligning our policies and practices with the CDC guidelines for appropriate pain management. Under the second strategy of reducing diversion of prescription drugs, one initiative in particular I wanted to highlight is the high-intensity drug trafficking area partnership. So this is a federally funded partnership that is occurring between law enforcement and public health. And what we are able to do with this partnership is provide real-time data to our law enforcement around opioid overdose outbreaks, emergency department visits, or opioid deaths that they can then use in their investigations of trafficking into our state. And you can see on the map, we have a few areas that are considered high-intensity drug trafficking areas, which coincide with the major routes we have through North Carolina. I want to thank the legislature's work on this Synthetic Opioid Control Act, which will also go a long way in closing the loopholes that we have around fentanyl. We know that as this epidemic progresses, traffickers are engaging in creating new compounds and new drugs, new types of fentanyl compounds specifically, that are making their way onto their streets. And so this will close some of the loopholes in our Controlled Substances Act to be able to capture those compounds as well as controlled substances. The fourth strategy was making naloxone widely available and linking overdose survivors to care. Recently, DHHS purchased and distributed nearly 40,000 units of naloxone. These are going out via opioid treatment programs, harm reduction coalition, through our EMS agencies and first responders. And we are hoping to not only provide naloxone to those that need it, but then to engage in, again, the linkage to long-term recovery and treatment for those survivors. And this is one piece of the work that we are doing, but there is a broad set of stakeholders across the state that are working to make naloxone available. This data shows across North Carolina counties how many kits have been distributed over the last 4 years. And you'll see that over 8,000 reversals have been reported with the kits distributed to date. The fifth strategy was increasing access to treatment and recovery systems of care. I wanted to highlight two specific things here. One is our opioid STR grant funding, which came to our state. You know, this is one piece of funding that comes in to provide care for those that are suffering from substance use and opioid addiction specifically. About $2.7 million of that has been expended and used for services such as medical detox, individual and group therapies, treatment, intensive outpatient treatment, and other services. This funding is also going to support training of providers in rural communities, specifically around office-based opioid treatment. So through a program at UNC, doctors are being remotely trained on how to better manage those types of patients in their own clinics. They do weekly case-based learning with the UNC Hub through video conferencing, and then are able to use that knowledge to better manage their own patient panels and become self-sufficient in managing those patients. And so that is starting off in 22 rural counties, and the hope is to expand it to all 100. Another aspect of increasing access to treatment that our Medicaid team has looked at is removing prior authorization for Suboxone film, and this change just went into place in November. And what this will do is allow those patients that are currently diagnosed with substance use disorder to engage in quicker access to treatment and this medication to move them on the path to treatment and recovery. And lastly, our strategy is to measure our impact and revise strategies based on our results. And for each of these things, we've created metrics that we will be monitoring and measuring and are part of the action plan, which includes many of the things and data points that I pointed out earlier in the presentation. And I hope that with these initiatives and with a lot of the work going around across the state, that I hope we can come back here and talk about how these numbers are starting to turn around. So thank you so much, and I'm happy to answer any questions.
First question will be from Chairman Dobson.
Thank you, Mr. Chairman. I have two questions, non-related if I can. First one goes to slide 3. Just a superficial glance of that.
Let her bring it back up on the slide projector, please.
Appears to be overprescription and deaths in more rural areas just at a superficial glance. Does there seem to be a correlation with overprescription in rural areas as opposed to the more populated areas? And if so, why is that?
Yeah, I'll explain the data in two ways. One is if you look at some of our more populated areas by sheer numbers, they have a higher number of overdose deaths because they simply have a higher number of people in some of those areas. This data goes by rate, and so certainly if you look at some of our rural areas, you will see that they light up in terms of overdose deaths. They have a smaller population overall, but a proportionately higher number of overdose deaths in some of those areas.
Follow up on that point, Mr. Chairman.
Yes, please.
Does that also mean that there's a link of overprescription in those rural areas?
Yeah, and so what we know about this epidemic is, yes, that there is a link between overprescribing and then subsequent overdose deaths. This is, I think, something that is changing now over time as more physicians are becoming aware of that link. And as more guidelines have come out, CDC guidelines have come out, there has been a lot of education of providers. So I think that is slowly changing.
Follow up on that.
Yes.
If that's the case, do you have any analysis or opinion on why the overprescription is greater in the rural areas versus the more urban areas?
You know, I think that there are really multifactorial reasons why we might see that in some areas. I think in some areas there is, and it could be legitimate. Sometimes in some areas there is more chronic pain. Some populations do suffer from more chronic pain. I think overall, access to providers and provider who are knowledgeable about CDC guidelines is, I think, one of the critical shifts that we're seeing. So, and I think that knowledge is penetrating across all of our areas, again, with a lot of the work around provider education. So while I can't point to one specific reason that might be the case, I do think generally providers across our state and even in some of our rural areas are getting the message and the training that they need to be able to make better decisions around opioid prescribing.
Thank you. I certainly hope so. Second question on a different issue, if I can, Mr. Chairman. On slide 20, you talk about bullet point 4, make naloxone widely available and link overdose survivors to care. I think that's an important point because to me, it wouldn't make much sense to administer naloxone if there's not a second part of that to link overdose survivors to care. What all does that incorporate, and how are we going about doing that?
Yeah, so I'll give you one example of that, and I think there's many things that go into that. But one example is the use of peer recovery support specialists. So we're finding increasingly, and there's good models of this in our state, where we have peer support specialists, for example, embedded into an emergency department who can follow up with a patient that has just come in for overdose and help them make that linkage to treatment and recovery. So that's one example. But a lot of it has to do with transitions of care and more importantly, access to treatment options. And I think that, going back to the earlier slide, I pointed out 50% of the patients that are coming into the ED right now are uninsured or self-pay. And I think another aspect of that is working on expanding access to insurance options for those patients so they can get long-term treatment and recovery.
Thank you, Mr. Chairman. Thank you.
Representative Murphy.
Thank you, Mr. Chairman. Thank you for that presentation. I think that's obviously one of the biggest challenges that our state is facing at this moment in time. Just in reference to Representative Dobson's talk, actually the state of North Carolina and the nation as a whole since 2013 has actually decreased its prescription or its prescribing of opioids by about 15%. Unfortunately, we've continued to see the rise. And it now, as one of your slides pointed out, I can't get the number because Dobson was throwing me off with the numbers on the slides. It was showing, hey, how about that? It was showing that the number of overdose deaths related to prescribed opioids has actually leveled out, but we're finding much more of the heroin, people going directly to heroin. Also, a lot of these folks are now finding that the Narcan, we're getting Narcan-resistant problems. My point, a couple of points and questions. Two things. I really should have said this during the previous talk about telemedicine. I would make a recommendation that when we're putting through telemedicine that opioids not be prescribed on that. I don't see that is really a good facet for this, especially with the problem that we're facing right now. Second, I think the linkage to individuals who receive Narcan out in the field who then refuse to be transported to the hospital, that's a difficult problem because those individuals, they can refuse it and they don't get treatment. And expanding our access to care for those individuals and the ones that come into our EDs is going to be critical to solve this problem. If you look at folks who administered Narcan, 80% of those people are alive 3 years afterwards. Actually, I'm sorry, it's about 70% of people are alive, but a third of those who are not did die from an overdose. So unless we get those folks into treatment, we're not doing anything. We're just continuing to spin our wheels. And that's one of our biggest challenges for our state. Our mental health system is broken, and we have to get folks into substance abuse programs if we're ever going to get a hold of this problem. I see that as really being the crux of this entire epidemic. We're working on the prescribing part, and I think we've made headway on that. We've worked on the synthetic opioids and getting them to be illegal. Our law enforcement are doing a great job, but if we don't complete that course of getting folks into treatments, we're not going to make any headway on this. So, thank you.
Thank you for that comment, and couldn't agree more. And I think, as you point out, I think along with prevention, we have a whole generation of folks currently experiencing substance use disorders, and I think how we move them into treatment and recovery for that population is important.
I did have one follow-up question.
Representative Murphy, yes.
The department had been given a request to study the on-site disposal of medications. I just was wanting an update on where that was. That's one of the avenues that we're having a hard problem with, is getting rid of medicines when they're in the cabinets and stuff.
That is in process now, and folks in our Division of Mental Health are looking at that issue now.
And I'll just follow up, Dr. Murphy, that we've had some great partnerships in that space. Inmar, in particular, has been a company that has helped us sponsor in a number of pharmacies throughout North Carolina the opportunity for folks to dispose of their meds in a safe way. So I think what you're going to hear from us is how do we further those partnerships to make sure in every pharmacy that they can be ready to take back meds that may not be fully used, so get them out of folks' cabinet.
Representative Dollar.
Thank you, Mr. Chairman. I've got several different questions, if I might. One of the questions, Dr. Murphy talked about it, and that is we've seen a real spike on this chart right here. Obviously, we've seen a huge spike in deaths related to heroin and other synthetics, and so the question is, what are we doing to address that issue?
I think that is an excellent question, Representative Dollar. Thank you for the question. Again, Susan Consagra. So this is something that we are seeing, and over the last several years have seen an exponential increase in, and we know that the flow of these drugs into our state is increasing, coming from multiple sources. In addition, traffickers are becoming, generating increasingly novel fentanyl compounds. One of the compounds that has been seen across the U.S., carfentanil, is actually an elephant tranquilizer that they have been able to manufacture. So this is a critical issue, and this is really where our law enforcement partnerships are critical. They, colleagues, SBI, our HIDA initiative, our law enforcement colleagues are looking at avenues to investigate and identify sources of trafficking into our state.
Okay.
And it's Secretary Cohen, just to mention one other thing you may not know, the FBI set up five command centers across the country. One of them is here in North Carolina.
A couple of other questions, Mr. Chairman.
Yes, go ahead, Representative Dollar.
One of those is, and maybe this is an observation for the chairs, y'all might want to consider a good deal of our substance abuse work in terms of treatment and all, and again, I think Dr. Murphy talked about this, is operated through our LME MCOs. One of your slides was showing the grants that have moved through the LME MCOs. So I guess one of the things that we might want to consider is bring in some of those representatives from some of those LME MCOs in a future meeting to talk about what's happening on the ground, what they're doing, and how they see that see this shaping up from their perspective. I think that might be helpful. A different line of questioning that I want to ask: have you been able to track what kind of diagnoses? I mean, getting back to the opioid issue itself, what kinds of diagnosis do you see most often involved in the over-prescribing? Do we even have any information on that? In other words, is it knees? Is it back pain? What is it?
That is something that we are trying to understand better, and is a great question. One of the things that we are seeing as we study this issue more, and really nationally people are identifying, is that there is a lot of variability in how prescribing might happen after a surgical procedure. And a lot of times that is based on how a physician might have been trained or the policies in place. And so one of the initiatives, as I mentioned, through our partnership with the Hospital Association, is better understanding that variability and where there are opportunities to promote guidelines, even in detail, as thinking about certain procedure types or surgery types.
So follow up on that. Will this Payers Council, it sounds good, but are they actually going to have the data? Do they have the data? Do we even know if they have the data to be able to say, okay, it's, there's one or two or certain classes of procedures where we're seeing this more prevalent, or not? It may not be if we don't have do we even have the data to make those assessments? Because that way you could target in a whole lot more rapidly on where some of the problems are.
So that is one of the things that we are looking at now, and those data sources, claims-based data sources, do provide some information to us. We are hoping to be able to better understand this, and as we learn more about this issue, and nationally, as we also see more studies about where there is greater prescribing, and particularly inappropriate prescribing, which sometimes that's hard to assess with the data, but this is something that we are looking at and hope to be able to get a better sense of.
Just a couple more, if I might, Mr. Chairman. One is on your action plan, you talk about measuring impacts, and I think there's actually a couple of references to measuring the impacts. Is that going to be an internal assessment, or are you going to have any external assessment of those things outside of the department?
That is data that we collect from a wide variety of stakeholders. And so some of the data is the data that I referred to earlier. We measure overdose death rates, which we have access to that. We measure ED visits, which we have access to. In addition, there are other metrics that we collect from stakeholders, such as naloxone distribution. So we hope to be able to compile those data points across the many stakeholders involved in this issue. And some of those are available with the action plan online as well.
Okay. Well, I think having some independent external assessment would probably be helpful in pulling all that data together. The only other thing I would observe, Mr. Chairman, is that in the opioid action plan above that, where it talks about expand access to treatment and recovery-oriented systems of care, again, a lot of that care is being managed now through the LME MCOs, and I think it would be good to, I'm assuming they're a key element to what you're doing moving forward, currently and moving forward, and it might be very good to actually hear from them on the ground what's happening around the state.
The staff is aware of that. Thank you very much, Representative Dollar. Senator Heiss.
Thank you, Mr. Chairman. I guess the area that I get a sense of is naloxone was a big push by the General Assembly and others when it came out, and it was, part of this answer for overdose deaths to be able to serve those. And I think most people had an expectation that when we made this drug available, we'd actually see overdoses rise. For individuals who were going multiple times now and having overdoses. But I think we all expected the fatality rates to fall, that you would see that, if you can get to someone who's overdosing, you can give them this medication, this would be a life saved. But what we're actually seeing in the data is that deaths are increasing at a rate maybe even faster than they were prior to this drug kind of being available. I'm also challenged, when you pull, I just had a chance to start looking over some of the most recent year data. methadone is still one of the number one OD drugs across the state that is supposedly a treatment drug for individuals trying to get off. Particularly in the western part of the state, I have counties where that's the highest drug that individuals OD on that's coming in. So as we come through these treatment plans, these new drugs that are coming out that are supposed to be the solution are in many ways coming as much of the problem that's going through and developing our numbers. How do you see those impacts of the medications out there, and is it really not that there's going to have to be a very different solution?
Thank you for that question, Senator Heiss. I'm going to take two parts of your question. One, I think going back to the naloxone question that you asked about, while we have been distributing naloxone increasingly across our communities, overdose rates are rising because we're seeing more particularly illicit drugs coming into our state. And so had we not had the naloxone, I fear that our numbers would have been much worse. And so while they are increasing, I think that is in spite of, not because of that naloxone, because of other factors that we're seeing increasing. Back to the medications like methadone, one of the gold standard treatment for substance use disorders is medication-assisted treatment, which is a combination of medication as well as behavioral therapies. And if we look at the data, a combination of those two things has been shown to reduce illicit drug use. It's been shown to increase gainful employment, reduce criminal justice involvement, and has many benefits. I think the key that you speak of is reducing inappropriate usage and diversion, but increasing access to medication-assisted treatment in appropriate manners to be able to provide real treatment to people that are suffering from substance use disorders.
And follow
up, Senator Heiss.
But with a lot of these drugs like methadone, the utilization seems to be these clinics that open up in the state and hand out doses up to 14-day treatment when the individual shows up at 6 a.m. in the morning, and that's kind of the limitation of their treatment. They start out, they have to come every day, and then they work themselves up to kind of a 14-day process. But there is no follow-up, there is no counseling, there is no, it's just kind of, that's the purpose of the clinic. It dispenses the drugs kind of coming out. How do you change prescribing mechanisms to ensure a broad compliance for the individual, not just necessarily a, did you pick this up today?
Part of the treatment for opioid treatment programs specifically is a combination of counseling and medication and access to those behavioral therapies. I think, your question goes back, Senator Heiss, I think to an important point, which is that we need to increase access to appropriate and effective forms of treatment, which is a combination of those things. And if we can do that, if we can get people accessing appropriate forms of treatment that are then, it has been shown to subsequently reduce use of, for example, illicit drugs or, inappropriate use of drugs. And so I think one of our key areas that we would like to focus on, and especially as we hear about people suffering from substance use disorders across our communities, is really increasing access to appropriate care, which we provide through our opioid treatment programs, but working also to make sure that the full spectrum of recovery support is also available to those patients that are then engaging in treatment.
And just a final area I wanted to kind of touch on. It also seems very unusual to me that when you're seeing in recent, particularly if I look at 16 and 17, these increases in fatalities, these increases in overdose. When I look at our ADACs, which is the highest level of treatment we've actually been seeing declines in utilizations of those services. And there is a real challenge for individuals. Apparently there's not as much need for the high-end service, but individuals can't find that mid-level residential required treatment program, and there's also some very complications. You can't go into those programs if the levels, you have too much of a particular level in your system, and then you got to wait till they come off. And I actually hear from people on the ground too that there's this whole halfway house and others that is becoming more avenues for users, that people are going into these and there's still access to drugs and others in them. You know, as far as controlling licensing of those things and others, do we look at that information? And what is that area of treatment that we need to invest in, or do we need to repurpose our investing dollars?
Maybe I'll take that. This is Mandy Cohen. So I think you're right in challenging us to think about the range of different types of treatment modalities for the opioid crisis, because it's different than the normal, I wouldn't say normal, the way we thought about alcohol treatment, for example. It is just a different modality of treating this disease. The neuroscience is different, the treatment is different, and thus the sort of service of treatment needs to be different. And frankly, depending on the patient, they need different things, because they may have use of multiple substances that we need to be aware of. They may have underlying mental health disease that may have driven them to be self-medicating in the first place. So I think it's needing to tease that out, and I think that's exactly the work that we're trying to do with our own ADACs. We're doing a review of that right now. When I joined the department, none of our ADACs were doing opioid treatment at all. Like, that was not, right? We're in the middle of a crisis. I fully recognize that that's not the right place to be. Now we have moved far down that path, but I think we also need to think about how do we adapt to the world that is changing around us. And so that is the work that we are running to try to do quickly. And so what I would say is that for a number of folks, that being inpatient and being residential, that's not needed. For some folks, it is the best place to recover. And there are places where medication-assisted treatment is not the right choice for some folks, and they do really well in other settings. So we want to make sure that we have the different array of options to folks, and that means looking at the safety net that we support, right, the ADACs and others, and making sure that we know where we fit in to the larger picture here, and make sure that as we are in the midst of a crisis, that we're being as responsive to that as possible. So we owe you some additional work on that we were running through to make sure we know where the future is for our state programs and our state facilities in particular.
Representative White.
Thank you, Mr. Chair. Senator Hayes asked my first question, so I guess my follow-up is, I've been in several counties recently in the last few weeks talking with folks about the opioid crisis, and their chief complaint is that in none of the counties that I've visited from the Triad to the east is there a treatment program at all. So my question would be, how far does a person have to drive typically in North Carolina to get to a treatment program at any level?
I think certainly it is variable across our counties. Thank you for that question, and I think one of the things that this points to, again, going back to the idea that a large percentage of people that are coming, for example, to our emergency departments for care right now do not have insurance or a mechanism to cover treatment, support, and long-term recovery. And I think this also goes into then the availability of facilities across our state and capacity across our state to provide those services. I think both of those things we know there is not enough of across our state, and we would like to increase to be able to better serve North Carolinians and those that are in areas that where they're finding that they need to travel distances to go to a program.
Follow-up from Representative White.
In keeping with that response, many of our small rural hospitals cannot provide treatment either. So going to the hospital to be, adjusted for what the crisis is at that moment does not provide any treatment, of course. So I think that is a real big challenge for this body and for you all. But I think at this point, based on what I've been hearing over the last several months or several weeks, it is across the state. There's just no treatment. There's just not adequate treatment. Thank you.
Madam Secretary, do you have a comment there?
Well, I wanted to say, I think, just to reiterate what Dr. Consagra was saying, I think it's access to treatment, but that access to treatment is, one, making sure that the providers are there, but also that folks have an insurance card that they could go to access those providers. And I want to make sure that we are addressing both. And it's a little chicken or the egg, right? How do we recruit the providers there if they say that there's no one there who's going to be able to access my services, right? So I think we need to think about both as we're moving through this. And I thank you for a number of you, whether it's Chairman Lambeth, yourself, Dr. Murphy, for thinking about how do we get more folks access to care and access to insurance coverage. I mentioned in my opening, right now it's open enrollment, right? I want folks to go and look to see if they qualify for an insurance coverage through healthcare.gov. Again, they could get a plan for less than $75 a month that, again, would cover a range of treatment options as well as ongoing insurance to care for them, whether to treat depression or the other things that were going along with their substance abuse disorder. So I just wanted to make the point that we have to think about the providers that are there as well as the insurance card that allows them to access that.
Representative Cunningham.
Thank you, Mr. Chair. I have several questions. The first question is the cost estimate to the state for the overdoses. And the second one, the wait time for a detox bed in the state of North Carolina. The third one is the length of time to get a long-term bed in North Carolina. And the last one is, has the population's identity changed at all since the interception of the epidemic?
So I'll answer actually the first question and the last question. Thank you for all those questions. And then I think we'll get back to you on the few that you asked in between, particularly on the wait times. On the last question you asked, to take the more recent question, you asked, have the demographics changed? I'll give you a sense of what the demographics show now. We're seeing, particularly for those that are coming into our emergency departments for overdose, there's two age bands that we see a more frequent visits. It's 25 to 35 and 35 to 45. A little bit more common in males, more common in whites. And we've generally seen this over the last few years. So that has been relatively constant. I think certainly as more individuals age with this epidemic, we're going to start to see ages change as well. Your first question, actually, you know what? You might have to remind me, Representative Cunningham.
Thank you.
Yeah.
The cost to the state.
Right. So, the cost to the state, one of the things that we know in this epidemic is the cost to the state. Actually, it's the cost to society. We're seeing the cost is not only to the state in terms of healthcare costs. There's costs to criminal justice system. There's cost around lost productivity from people that are no longer able to work. So the cost, far exceed any one medical cost. If you look across the country, they estimate that the cost of the opioid epidemic is more than $75 billion when you take into account all of those things. So, certainly a huge cost to our state. I think it goes beyond healthcare costs alone. And again, I think this speaks to what we're doing around ensuring prevention and access to treatment, because we'd rather pay now than pay later. And I think if we invest up front, that we can significantly reduce some of these downstream costs.
And if I could, on the cost piece, I know we've been talking a lot about insurance access for the treatment part, but I want to pick up where Dr. Gonzalez was talking about treatment to prevent folks becoming addicted in the first place, right? So if you have access to insurance and you have depression or you have back pain, two triggers that we know are very likely to potentially send you down the wrong path, you can get your depression treated, potentially have other modalities to treat your back pain like physical therapy or other, right? As opposed to trying to self-medicate with maybe something that you're finding on the street and going down the wrong path. And so we talk about often access to insurance to get to the treatment after we're already down a bad path, but I want to make sure folks make the connection that getting access to insurance also is a preventative measure in and of itself. And there's good data that I'm happy to share with the committee on that as well.
Senator Fauché.
Thank you, Mr. Chairman, and thank you, Dr. Consagra and Dr. Cohen, for those last answers. I guess my question is, what else can the General Assembly do to help fight the opioid epidemic?
Thank you for that question, Senator. I think one of the most important themes you've heard me talk about and throughout this is really the access to treatment and recovery. And while we are working on prevention to prevent a new generation of folks to become addicted, what we do see now is we have a, society, communities, family members, loved ones in our community that are suffering, and increasing the capacity of our state to effectively treat and provide that long-term path to recovery is so important. And I think that goes back to some of the earlier conversations here around, one, increasing access to insurance for those people to be able to engage in long-term treatment and recovery, to be able to support, again, you're seeing people coming in and out of our EDs. That's not how we manage a chronic condition, really the access to long-term support and care.
Representative Dollar.
Thank you, Mr. Chairman. I just wanted to kind of go back and maybe make a comment. And I know you, Mr. Chairman, you directed staff take a look at bringing in hopefully the LME MCOs to talk about this issue, maybe at the next meeting or a future meeting. And I say that because, the issue of ADAX was raised earlier. And as you know, or some of the public may not be aware, but we've been in the process of shifting the funding for ADAX to flow through the LME MCOs. And that's an ongoing process. I don't know if it's finished now or not, but it should be here shortly. There's also questions with regard to what is going on with regard to treatment, and I think that they could answer a lot of those questions, what's going on right now on the ground, and in particular, not just with Medicaid, but those single stream dollars, those state dollars also go into some indigent treatment as well in terms of substance abuse. And it might be good to hear what is how those dollars are currently being used, and maybe address some of the issues of sufficiency therein and the like. Thank you.
Thank you. All those are noted, and we'll certainly consider them. Representative Adcock.
Thank you, Mr. Chairman. I'll just point out something I know is obvious to everybody. I think it's great to invite the LME MCOs to come and talk about treatment options for a Medicaid population, but I don't want anybody in here to think this is a poor person's problem, because it isn't. I work in a family practice where I would dare say the majority of our patients are middle class to upper middle class, and this cuts across that. So I think it's great for us to talk about treatment for our Medicaid population. That's wonderful, but they are not carrying the burden of this problem alone. And so we have to look across all of our citizens and what they need. So when Donna talks about, and Representative White talks about no treatment programs in 4 counties, she was just telling me, certainly people who don't have access to care right now have that problem, but so do people who have insurance. I'm talking to families who have, still carrying dependents to age 26, and they cannot find residential treatment for their children in this state at all. They're sending them to Florida, to Utah, to other states where they can find this care. I believe we can do something similar. Thanks.
This has been a very engaging section of our briefings today. Thank you very much, Dr. Consagra, and our Secretary, Dr. Cohen. Thank you very much for your inputs, and thank you, committee members, as well. Going on to Section 5, Controlled Substances Reporting System update. That's the CSRS, which I'm sure you're all familiar with. Mr. Charles Carter, Chief Operating Officer for Technology and Operations of the Department.
Good morning, Senator.
Good morning.
Thank you very much for giving me this time and bringing up this subject. So we are currently in a procurement process right now to procure a new vendor for our CSRS program, or Controlled Substance Reporting System. So I will have to be careful about how we discuss this at this point. Our goals for the future state, we have a contract that's ending at the end of this calendar year. We are looking at the goals for how we want to proceed with the next iteration of the CSRS platform. And so I'm going to discuss those goals here and then give you a brief timeline, or not timeline, but next steps to achieve that future state. So the first part of this is that we've understood and we've heard from previous presenters that the interstate connectivity for two-way communication of data is critical towards the success of any kind of treatment program, of any kind of ability of providers or regulators to actually get in control of this epidemic. So one of the key features we're going to have to call on our next vendor is to have a very robust, or who looks to have the most robust data connectivity throughout the country. We're in a very mobile world, so people can drive and fly from all over, and we want to be able to track in as close to real time as possible any kind of data that's on the CSRS system nationally. The next is to look for a vendor that has electronic health record integration. Many of our providers, as you know, it's very difficult for them because they're going through multiple portals in order to upload data. So they're working through their EHRs, and they're also working through if they have the EHRs. And then if they don't, then they're also working through the CSRS web service portal. So what we want to do is find a vendor that actually integrates through the EHR system so that we can cover as much of the state and then look to expand that as we expand the EHRs throughout the state. We also want to make sure that we have a robust, even more robust than we currently have, data channel through to the HIE and to GDAC. As you have heard earlier, we're looking at very difficult and messy fixes. So the GDAC and HIE are our kind of first line of looking at a variety of data sources to kind of help us navigate this epidemic. So actually having robust data dumps every night so that we're getting the full spectrum of data to the HIE is going to be critical for our next vendor. And of course, whenever you're procuring a new IT vendor, there are new aspects that they have, or new functionalities that they have in their platform. So we'll be able to look at the variety of new technological standards that are available to see if we can bring those into the state to help us with this particular situation. So those are the primary goals that we have, and the next steps that we have to achieve those. The first step is that we have to extend our current contract. We did have a contract with a company called HID. HID was purchased by APRIS, and that contract actually ends at the December 31st of this calendar year. So we are in the process, and you may have seen me checking my phone because it's imminent, of getting that new extension executed for the next calendar year as we look to procure the final product that we'll be bringing on board. The next aspect is to execute a memorandum of understanding with the National Association of Boards of Pharmacy. The NABP has worked with actually APRIS to develop a platform for interstate connectivity, data connectivity. We currently are not connected to all of our states, including our neighboring states, and they're not receiving data from us. So this will be, once we get this MOU, which again should be very soon, we will be able to, even with our current platform, exchange data with all of our neighboring states and actually about 40 other states and territories throughout the country. After we do that, we're going to obviously procure the next vendor that meets the goals that have been established in session law, as well as the goals that we've heard from our providers, as well as our dispensers. Then we will develop the process to integrate the providers to the EHRs and the new platform. And again, this is at no cost to the providers. We want to remove all of the barriers possible to get the providers to use this system as part of their clinical checklist as they move through how to best treat their patients. We want to be able to provide as real-time data as possible for them so that they're not waiting on information that should be available in today's society, in today's technology. And then last is training the dispensers and providers on this new platform to make sure that we get near 100% of providers and dispensers using the CSRS and using it on a case-by-case basis, as opposed to in their current system of having to go to one portal to do one set of work and then go to the CSRS portal to do another set of work. That barrier has proven to be something that we've had to work to overcome and are still working to overcome. Hopefully we can streamline that so that they only go into one portal, and that will make it a lot easier for the providers and the dispensers to utilize the data that we are providing through the CSRS. So I'll entertain any questions if you have them.
Thank you very much, Mr. Carter. The chair has one question to start off with. I believe I heard you say that the department will soon be, or perhaps it's already in negotiations, to get a new vendor for CSRS. Is that did I state that properly?
We are not in negotiations with any specific vendor. We are looking at the marketplace right now to decide what next steps. The only thing that we're in current negotiations about are the extension of the contract that we currently have, and with the memorandum of understanding to get interstate connectivity. The next stage will obviously be a procurement and looking at the vendors and what the marketplace bears.
So is there a requirement that we change vendors now, or is it the opinion of the department that we need to do it for other reasons?
Well, our current contract is ending on the 31st. Our contract is with our platform is actually an older platform. It's the HID platform. That company has been purchased by Appriss. Appriss obviously would like us to use a different platform, but there may be other vendors as well that have other platforms that may meet the goals that we have. And so with this contract ending, it's just a healthy opportunity for us to be able to look at what's available in the marketplace.
Question, Representative Murphy.
Thank you, Mr. Chairman. Can you go back to just the second slide? I just wanted to ask, you talked about the EHR integration with all North Carolina providers at no cost to the providers, which I'm very happy about. I want to know, how difficult is that going to be?
We work within the budget that you give us, and so I don't think it's going to be our initial plans. The early discussions that we've had with providers who are currently using things like Epic or Cerner is that they will work tirelessly to connect those connections, to make those connections. I think when talking with rural health, for example, we've got to make sure that the providers that are in the rural areas are being able to connect to the CSRS system or through their electronic health records. So that's where our costs that we will incur. But again, our goal is to make it at no cost to the providers.
Follow-up?
Follow-up.
Just in that, if you're dealing with companies like Epic or Cerner, what has been their history? I know their Epic, being the major monopoly in the country, hasn't been the most accessible to change their basis and to change their platforms and make them more user-friendly. What has been their record of success in being able to do this?
So we haven't, obviously we haven't picked a specific vendor for the CSRS to be able to answer that question specifically about their integration into Epic or Cerner or any of the others. But we are making that a high priority. We recognize that Epic has a large footprint in North Carolina. It's about 70% of all the providers. So we have to make sure that we have one of the standards that we have for a new vendor is that they have a easy connection to the EHR of Epic. So far, the early conversations we've had is that it's a very positive response from both Epic and the providers out there that would be facilitating that connection.
Okay. One other question. I'm questioning, why can we not do this in-house with the new HIE coming on board? Why do we have to go to an outside vendor?
With the new HIE on board,
when we're developing our new system, I'm looking at the cost. If we're talking about moving to another company, what cost overruns, or how much more costly do you think it's going to be in the future?
Our goal is to not only stay within the bounds of the costs that you've appropriated, but to actually come in under those. I think we have had multiple conversations with various vendors. We do not foresee a problem with staying within the budget that has been allocated by the General Assembly.
Just one other follow-up question.
Yes.
And this is just a sideline issue with that. Part of the STOP Act, we are looking to try to make electronic prescribing of opioids a mandate or a requirement, unless there were some unforeseen circumstances. Finding out now that EHRs, just like when the EpiPen went up, the price of that went up. When people are requiring this, they're going to require me as a provider to pay up to $1,500 a year just for that privilege of having to e-scribe. I'm really just concerned about the cost, just another cost on providers for this, and I would just applaud you, but also just implore you, rather, that you don't let these big companies bully you around to just put just one more cost on providers.
Dr. Murphy, I'll take that one, and I think you know that in order for you to continue to receive some of your Medicare payments going forward, you're going to need to be e-prescribing as a doc anyway, and so I think there's a lot of alignment in the market from payers across the board. So while there will, there's always maintenance and updates for any technology product, I think being able to spread those across your whole patient base and not just a solution for our Medicaid population, a solution for your commercial, a solution for Medicare, as long as we're all driving in the same direction, and we're all, again, and that's why we are so focused on getting something that can integrate into what folks are already using, and again, not to do something outside of it to add a different layer of cost. That's where we're focused.
Any further questions from members of the committee? Senator Davis.
Thank you, Mr. Chairman. Thank you for your presentation. My understanding is that you're within budget and you don't foresee any cost overruns. Matter of fact, you anticipate being able to complete the project maybe under budget. Is that correct?
That's our hope, certainly, but we're definitely
just overpromised there. I mean,
it's just
but
a
thank
hope.
you for your support, Senator.
One other question, Mr. Chair, if I may.
Go ahead.
How close are we to having a nationally recognized platform so that all these providers with, most providers now use practice management software and stuff, so that it's totally integrated, so that this is seamless across all providers? How close are we to developing a national standard, or is that something that we'll ever get to?
There's a lot of work going on at the federal level to establish national standards on electronic health records and how do we share information and the standards. That is like a whole body of work that is more challenging, right? Because everyone likes what they have already and don't want to give up and move to what someone else may have. But that work is progressing, and I think that's exactly right. I don't think it means that everyone has to have the same vendor. It means that we need to have the same standards and again, allow that exchange of information, and so that we don't keep having that information in silos, whether we're talking about the opioid crisis and prescribing data or any clinical data. I think we're trying to liberate that data so it can move freely throughout the system, so that it follows a patient through their experience of getting health care. So that there is a lot of work going on. I'm happy to come back and talk about some of the work that I did in my previous life. A lot of that is driven by the Medicare program and the rules around that and meaningful use and things that doctors will get upset about over there when we say the words meaningful use out loud, but that's where a lot of those standards and things are headed, and how we use some of the payment levers we have to sort of drive that integration, drive that standardization.
Seeing no further requests for questions from members of the committee, we will move on to our next item on the agenda, item 6. Report on the use of the Dorothea Dix Hospital Property Fund to increase licensed inpatient behavioral health beds. Mr. Steve Owen from our committee will start the briefing, and then Mr. Mark Benton, Deputy Secretary for Health Services, will continue.
Thank you, Chairs, members of the committee. I'm Steve Owen in the Fiscal Research Division. What I'm going to do is provide a brief summary of the legislation around the Dorothea Dix funds. Again, as a reminder, as much as anything, as well to provide some context for the comments from the department. In both the 2016 and 2017 budget bills, there were two separate non-recurring appropriations in each year. Both had the intent to, one, increase beds in rural areas throughout the state with the highest need, as well as to establish or increase the number of facility-based crisis centers in North Carolina for children and adolescents. In 2016, the appropriations were $18 million non-recurring for the construction or conversion of inpatient beds. In 2017, that was $17 million of non-recurring money for the construction or conversion of beds. In both years, there was $2 million appropriated for the establishment of child and adolescent facility-based crisis centers. In terms of the use of this funding, in the 2016 legislation or budget bill, it required that at least one hospital in 3 separate regions of the state would receive funds out of that $18 million pool, and it required a competitive bid process for up to two facility-based crisis centers for that $2 million. In 2017, a different approach was taken, where actually there were 5 facilities identified that would receive that $17 million funding, and specifically up to a maximum amount of how much each one would receive. And again, there was a competitive bid process for the adolescent and child facility-based crisis centers. I've indicated on this sheet, which I believe you have a copy of, you can see the naming requirements, as well as that each of the facilities would be exempt from CON through this process, as well as some stipulations. One of the stipulations that was shared in both legislation was that at least 50% of the beds that came about as a result of these funds would be reserved for the state to purchase either through our 3-way bed program or through LME MCO referrals. Today you'll hear the report that is due, I believe, actually is due November 1st of this year. I also want to give you an update on terms of the funds themselves. As of the end of September, there was about $50.9 million that remained in the fund. Over the last 2 years, the change in that amount has really been related to the growth or the interest that's been earned on those funds. So at this point, no funds have actually been taken out of that. When you apply the appropriations, or how much of that $50.9 million has been appropriated, there actually remains about $11.9 million of funds that have not been appropriated. And as of the most recent legislation, it also says any funds that are not expended, as it talks about here in terms of the allocation, would actually remain in the funds and not be used for other purposes. Mr. Chair, that concludes my comments.
Thank you, Mr. Owen. Are there questions from members of the committee? Hearing none, we'll go on to the next portion of the item 6. Mr. Mark Benton.
Thank you, Mr. Chairman, for the opportunity to give you an update. I thank also to Mr. Owen, who gave you a great briefing on what our charge was, not only in the 2016 budget bill, but also more recently in 2017. My remarks to you today are going to be focused on the earlier budget bill, which was House Bill 1030, Session Law 2016, Chapter 94. And in that legislation, we were charged with actually 2 different activities. One was identifying through a competitive bid process, as Mr. Owen mentioned, 2 different providers around the state to provide child and adolescent crisis beds. I'm pleased to report for that activity that we have actually identified both of those, again, through a competitive bid process, The contracts have been executed. The work is underway under both of those projects. And as you'll see, one is housed in Buncombe County that will be comprised of 16 beds. They are targeting to be opened by the end of the first quarter of next calendar year or March of 2018. We also identified a second vendor here in Wake County known as Kids Peace that will also open up a 16-bed unit, and their construction will actually take a bit longer, and they'll be online in March of 2019. The larger of the tranche of $20 million that came out of the Dorothea Dix proceeds, and just as a reminder, when the property was sold, that actually netted the state just under $52 million. So this 20 comes from that. The $18 million that was actually targeted for adult short-term inpatient hospital beds, again, through a competitive bid process, we identified a vendor in each of the three regions, both Eastern, Central, and Western. Those RFAs have gone out. Bids have been reviewed and accepted, and we've identified the three awardees being Southeastern Regional Medical Center, more specifically in Robeson County, Duke Life Point at Mariah Parham Hospital, just to the north of us in Franklin, or to the east of us in Franklin County, and also Charles Cannon over in Avery County. All of those contracts are currently under negotiation. We've had a little bit of delay in getting those contracts fully executed. Some of them were dealing with site issues. We actually, I think with the Duke Life Point, there was an underground fuel storage tank that sort of held things up. Another vendor, I believe, was in Charles Cannon, a worthy project, but they were asking us, I believe, to bring in a third party, and so we have working through all of those issues, but we expect to have all of those contracts executed early next calendar year, and once those contracts are executed, money will flow, and these projects will be well under their way. And that concludes my remarks, Mr. Chairman. Thank you again, Chairman Pate, Chairman Dobson, Chairman Lambeth, for the opportunity to give you this update.
Thank you very much. Appreciate that, Mr. Benton. Before we get into questions that are directly directed at these three properties you're talking about, and to the Secretary earlier this morning, I told her that I had seen something on an email overnight that I couldn't quite remember what it was, but it's the Cherry Hospital. I think some beds are being opened up there, and some more medical staff is being hired. Are you ready to comment on that now, or would you prefer to wait till a more opportune time?
No, I'm happy to. So Cherry Hospital opened September of 2016 and was phasing up their staffing because they had more beds than they had in their previous facility. And we've been able to do a big push around hiring additional psychiatrists as well as other nursing staff to bring on board another 50 beds, 60 beds. I think we still have one more unit that we have to open, and that will be happening in the next couple of months, and then we'll be fully operational at Cherry Hospital. So it's been a good success there, but happy to answer more questions.
Thank you. That's indeed good news. Don't think there's enough out on the street yet for us to ask any logical questions about that, so we'll just continue on with the rest of what's on this. Representative Dollar, I see your hand is coming up for a question.
Thank you, Mr. Chairman. A couple of questions. The beds that we're looking at for family preservation, Kids Peace, and then the other ones from the property fund in Robeson, Franklin, and Avery County. Will these beds be used to move people out of emergency departments? How's that going to work operationally? And will the funding for these beds, are they flowing directly through the department, or are they flowing through other entities in terms of the ongoing operations?
Mark Benton, thank you, Representative Dollar, for your question. I'll answer the second one first. that for each of the beds that come online, I think that Mr. Owen mentioned that half of those beds needed to be available to serve the Medicaid and indigent population. I think they're also known more commonly as three-way beds. The other beds would certainly be available for other commercial insurers to use. To your first question about what is our hope that these beds will do to perhaps alleviate the overcrowding currently in our emergency departments, and our hope is that yes, that it will do that we will be able to serve people more locally and be able to serve them closer to their homes and before they actually have to receive services in our state psychiatric hospitals.
Okay. Just one follow-up on that, Mr. Chairman. So when you say Medicaid for the portions of the beds that are being operationally paid by those patients, those funds are moving through the LME MCOs to pay for that or not?
Mr. Chairman, I will certainly defer to my fellow teammate Dave Richard to correct me, but for Medicaid payments for inpatient, I assume that would be a part of the Medicaid capitated payments that are paid to the LME MCOs.
Thank you.
Let the record reflect that Mr. Richard was in agreement with that from the motion of his head. Further questions? Representative Earl, I'm sorry.
Thank you. I've got one question, and maybe it was answered, and I just didn't pick it up. Of these facilities that have been identified, did they apply, or how did we come about to get these? Because I know of some hospitals that have empty beds. I get medical health beds, but they have more vacancies than they have actual patients to fill them. And so I'm just trying to see how you came about to get these, and what was the process, if you don't mind.
Mark Benson, thank you again for the question, Representative Earl. For these facilities, all 5 of these listed for the 2016 session, they were all competitively bid. So we actually put an RFA out on the street, invited people to submit their ideas, their bids, and so we went through a thoughtful process of reviewing those and identified the best candidate in the Eastern, Central, and Western regions. What will be different in the 2017 selection, as Mr. Owen mentioned, was that those were actually identified and have a targeted allocation from the legislative body.
Thank you.
Further questions from members of the committee? Seeing none, thank you very much, Mr. Benton, for the report you have given us. Now we'll move on to our final item on the agenda for today. Item 7, the traumatic brain injury, which has certainly been at an area that requires a lot of attention, and I'm delighted we have an opportunity to hear it discussed today. First speaker will be Mr. Dave Richard, Deputy Secretary for Medical Assistance, and then back to Mr. Mark Benton, Deputy Secretary for Health Services. Mr. Richard.
Senator Pate, thank you so much, and I'll go through the slides, and then when we get to questions, both Mark and I will be prepared to answer those. And first, let me thank you for your leadership on traumatic brain injury issues. You've been a stalwart for that, and we certainly appreciate your advocacy and the work that you've done on this. So thank you, Senator. And the slides here are very quick. We have want to give you an update of where we are on the adult and pediatric TBI pilot program. And just a reminder for that is that the intention of this is to increase compliance with the internationally approved evidence-based treatment guidelines. And really 3 clear goals. One is the reduction in patient mortality, the improve the patient level of recovery, and to reduce long-term care costs for the state and for those individuals. The pilot focuses on adult and pediatric populations with severe classifications of traumatic brain injury. and it will occur in 3 to 5 trauma hospitals licensed by the state. These are what the legislative parameters were for the pilot. We have been working collaboratively between the Division of Mental Health, DD, and SAS with Division of Medical Assistance to develop the request for application to put on the street for this. We believe that'll be, well, no, we don't go beyond believe. That will be finished and out on the street before the end of the year to identify the contractor for the pilot implementation. And then as soon as that's out on the street, we'll begin the process of reviewing the applications. We anticipate that we'll have that finished within the first 2 months of the next year and then ready for implementation at that point. I also wanted to take the chance to just give you a quick update on the Medicaid waiver for TBI. It seems like it's been going on forever. It has. We are encouraged now that we have provided the CMS with the answers to their questions. We're in about the 60th day of the 90-day process that they have to respond. So we're anticipating a positive response on this waiver. We had an opportunity last week while at a conference with Medicaid directors and CMS to encourage them at the central office and the regional office to really move this quickly. And mentioned that we would have to be responding to you, Senator, so that to try to help them speed this along. But we are hopeful that this will be done before and finalized before the end of the year, that we can start implementing. I'll flip to the next slide because the request also was just to give a quick overview of the statistics around TBI. And what we pulled is the CDC estimates of the prevalence rate to be about 2% of the population. If you do that in North Carolina, we're thinking somewhere around 200,000 North Carolinians would be affected by TBI. The other thing we did is we went back and looked at our information from July of 2013 and 2015. And what we can pull easily is the Medicaid information, looking at the ICD-10 codes, non-codes at the time, for both the mental health services provided through Division of Mental Health and through Medicaid. And when we pull those, what we find are about 113 individual consumers who had a TBI diagnosis that met one of these 7 diagnosis codes. Now that, again, is a snapshot in time, so we most likely will have more individuals that would have continued since then. But I think it gives you a good indication from that point of how many folks that would have been in the state-funded service system availability. And again, for those that have Medicaid, there are certainly services that are available there. We're hoping that the waiver expands those services for individuals who've been working home, and that this pilot project will help us be more effective in the work that we do for all individuals who have traumatic brain injury. So I'll stop there, Senator Payton, see if you guys have any questions.
Thank you, Mr. Richard. On this slide here, it looks like 2% is the estimate as to how many people are affected, and in our state, in which it says 200,000. I guess we can all read that. But the question I'm trying to get at is we have, I would say we have a disproportionate number of military veterans in our state. And so does that skew the number to any extent at all to raise it up above the 200,000 expected?
Senator Payton, Dave Richard again. It's a great question, and I would tell you that I believe that's correct. It will skew it up some. I don't think we have the evidence at this point, but we'll go back and try to do a little bit deeper dive to make sure that we're adding in the potential for those veterans and what it would do to our numbers. It's a great question.
Questions from members of the committee? Dr. Murphy.
Thank you, Mr. Chairman. Dave, could I ask a question? There's a growing body of evidence that hyperbaric oxygen therapy may be effective where other treatment modalities have not been effective. Is there any movement on the department's point to look at that as possibly being a covered item?
Representative Mercy, we have heard that, and we obviously know that there's this growing interest in body. We have not included that in the service coverages that we have today, but we'll be happy to go back and do some more research and come back to you with that.
I would appreciate the follow-up on that. Thank you.
Representative Dollar.
Thank you, Mr. Chairman. A couple of questions. I guess one of them is just the frustration, with the waiver. I mean, it just doesn't seem like it's been a priority. I mean, it is where it is, but I know we've been trying to get that done for, it seems like a long time, and General Assembly's provided money over a couple of different sessions. And so let me just express that, and you know, I think to me it's a frustration. Now, also, let me ask this. The legislature established, if I recall it correctly, Brain Injury Advisory Council. What has been the department's interaction with the Brain Injury Advisory Council? And, you know, do we have any comprehensive reports about the TBI service gaps that we have and what we're actually going to do to address those?
Representative Dahl, let me start by expressing my shared frustration around the waiver, and I think everybody on our team does that. We've found ourselves in a unique situation with the TBI waiver. I won't go into great detail unless you want me to, but the state had a requirement to develop a home and community-based services plan to submit to CMS. That plan is something that every state had a requirement to do based on all of our long-term supports and services. In the process of that, there was a requirement that for any new waiver, you had to have an approved plan that you would be able to have that waiver approved. And it had to meet all the standards that you were putting out there. So an example would be for our innovations waiver, we have to go in and make sure that we're in compliance with that home and community standards rule, but we didn't have to do anything about changing the waiver. We'll continue to provide the services. But for new waivers that came in, you had to meet all these additional requirements, and that's really been the delay. I think we've made significant movement with CMS. I believe we've got an approvable waiver that's within the guidelines of our home and community-based standards, and we should get that done rapidly. But again, from the standpoint, I think from all of us is that we're looking forward to this getting done quickly, and we've expressed that to CMS pretty clearly. So understand what you're saying. On the second question, we have, I would say we have great interactions with the TBI community through that advisory committee and through multiple other places that we interact with them. We have assigned staff from both Division of Mental Health and Division of Medical Assistance that attend all those meetings and work directly with them. I think to answer, do we have a comprehensive view of exactly what services are needed? I think that the team has been working closely with that advisory committee. We believe that we're getting better at determining what they are, which is why the waiver was developed in the first place. This pilot is another example of that. But are we doing everything we need to do? I clearly would tell you no, and I would suspect that's what the advisory committee would tell you. It's a process that we're developing to try to get better at this.
Well, I mean, I do think that's the frustration. I think we've been at this for quite a while, and you know, whatever processes are to be blamed, it just seems to me that we've got a growing need. We know we've got a need. It's a need that's been identified for a number of years, and it seems to me we've got to get on with the business, whether it's us doing more at the General Assembly or the department, or you know, coordinating it. Where we're actually increasing access to services that these people need. I mean, I just don't see it and feel it out there. We come and we talk about it a lot, you know, for a number of years. But I'm just wondering. I'm concerned about how much progress and with respect to the pilot. I hope the objective of this pilot is actually to increase access to service. Because if we're really not doing that, you know, we're not achieving anything here, and I'm concerned with, you know, are we making full use, for example, of that council, and are we identifying the gaps? Are we moving the ball down the field? And it just doesn't feel like that we are at all.
Representative Cunningham.
Thank you, Mr. Chair. I had a constituent a while back, and her son had an acquired brain injury, which is not covered under this particular policy, which came from like meningitis. And I was wondering why that was not included. When trauma is acquired, if you get an infection in your brain, it's acquired as well. Can you explain that to me?
Representative Cunningham, I think I want to get back to you with a lot more detail on that, but at the highest level to tell you is that from the very beginning of our program, it was traumatic brain injury and it wasn't acquired brain injury. It's an issue I know that we've had a lot of conversations with the TBI Advisory Committee, and I believe that's something that as we continue to come back with recommendations to you, we'll include in those recommendations.
Representative Adcock.
Thank you, Mr. Chairman. I wondered while Mr. Richard was talking about the giving an update on the status of the Medicaid waiver, if we could hear where we stand with that. Is that, I don't mean to ask that out of left field, but just curious as to generally where we stand. Thanks.
Well, what I'd say is I think we're spending most of the afternoon session on that, but I didn't want to step on our own thunder here.
No, I
at
totally
the
get
afternoon,
it.
but
Thank you so
we'll
much.
spend most of the afternoon on that. Yep.
So that would be something coming after lunch. Any further questions from members of the committee for the staff? Well, this was certainly a timely item in today's agenda as well, as all of them have been. I think we've covered a lot of ground. The department has been open with us, and we certainly appreciate that. And it's been very informative for this morning. And as I think Mr. Richard said, there'll be another meeting this afternoon on Medicare. Is that right? Yeah. And so we're looking forward to that as well. There being no further business to come before our subcommittee, this meeting is adjourned. Thank you very much.